on this computer. Okay, now we're recording. Okay, so I'm sorry that this projector, Jenny, this side is not working. Log into the Zoom if you want. You can follow along with me there, or there are a few seats over here.
Yeah,
It's oh, maybe the bulb is out or something. Okay, I'll let somebody know. So for when the guest is here, if you guys you can just listen to him and follow on Zoom, like I said for mine too, or honestly, we can squash over on this side. So I know it's uncomfortable, but we can do that. Okay, so I don't want to take too much time because I want to make sure that we have time for our guest speaker, and maybe I can grab someone to come in the interim, like maybe I can run over to ISU and UIS or whatever that's called and see if they can help us with that before the guest speaker starts. So I'm just going to do an overview of the gastrointestinal system. Your textbook really doesn't go into much depth on the system. It talks more about just medications. So and this PowerPoint, I kind of adopted a lot of these PowerPoints from the previous teacher. So sometimes figuring out like where they got information and why they're focusing on certain things can be kind of challenging. So I thought that last year, and I did a little bit of kind of changes, but I didn't change it drastically. And I thought the same thing. I was like, okay, I'm not sure why they're presenting this specific information. But I think it's probably overall just good to have a background and understanding, and then you can apply the actual medication. So we're just going to roll with it. The objectives: explain the main function of the GI system, identify the main organs and accessory organs in the GI system, explain the role of the liver, gallbladder, pancreas in digestion, explain the functions of each cell in the gastric mucosa, and discuss pathology related to the GI system, including cause. I don't know if you guys noticed, there was, I was looking at the study guide. Oh, I have it here. I was looking at the study guide earlier this week, and one of the questions says, what medications can contribute to GERD? What medications can contribute to GERD? And I was like, what? Did anyone else feel like a what? Nobody? Or has anyone looked at these yet? So that makes me think that we're talking about medications that can, and so NSAIDs, like maybe but I don't know what other medication. It didn't feel like that was drawn out specifically anywhere that I could see. So I didn't know if anyone else felt that. So if you leave that blank, that's fine. I'm going to end up changing that on the handout. Okay, so steps in GI. So your steps in digestion. So our GI system is pretty much like it says here, like a disassembly. Instead of assembling things, it's disassembling our food, breaking it down into all the things that we need, all of our nutrients and all the different things that we need, glucose for our energy, and vitamins and minerals and fiber, and then taking out the water and all of these things. So it's disassembling everything that we need for either usefulness, or it just goes through our system or stores it for later. So the GI tract is basically a disassembly line. The goal is to chew our food super well, break it down, starting in the mouth. So a lot of times we don't think about our mouths as the part of the GI system, but it is. So it's, the opening of the tube and then the whole thing, and then it exits out. So when we start to eat our food and chew it really well, and those enzymes are breaking down our food, that's the first step in digestion. And so many people talk about, I'm like the ultimate worst at this. I literally inhale my food. And they talk about, I don't know if you've ever heard, like chew your food like at least, what is it? Now I don't even remember, like 20 times or 30 times before you swallow. Like you make it like an absolute mush paste in your mouth, and then you swallow. And that benefits so many other systems down downstream. So a lot of us don't do that though. We just like, take 3 chomps and then down the hatch it goes. At least I'm terrible about that. But digestion starts in the mouth, enzymes in the saliva, and of course our masticatory function, mastication starts the process of digestion. So then we have the steps in digestion. We have how each component is kind of broken down a little bit more and a little bit more to its sort of the smallest increments. So carbohydrates get broken down to disaccharides, and then down to monosaccharides. Proteins get broken down to peptides and then to amino acids. And then lipids get broken down to diglycerides and then down further to fatty acids. So that's sort of how we break things down to get the most bang, or how our body utilizes it in its most basic broken down form. And the GI tract is not just the stomach and intestines, like I said, but it starts in the mouth. So we have the mouth and the pharynx, and then it comes down into the esophagus, down into the stomach. First, it enters the small intestine. So a few important things to note here is the duodenum has a few things that are of interest in this chapter. There's some diseases that take place in the duodenum that we'll talk about. And then also it's the primary place for nutrition to be absorbed in the small intestine. So it's important for you guys to remember that the jejunum and the ileum we don't really focus on. Those are the 3 parts of your small intestine. So duodenum, jejunum, and ileum. But the most important thing for this class is to just remember the primary absorption from the duodenum, and then peptic ulcers can take place in the duodenum. And we'll learn more about that later, especially when the guest speaker comes. And then we have the large intestine, the colon, the rectum, and the anus, which isn't on there, but our guest speaker talks about that as well. So that's the whole GI tract, the whole system. There's a video here. I think it just kind of probably highlights those parts, but we won't watch it, but you can watch that later on your own if you want to. So just kind of going into it a little bit further. So these are called accessory digestive organs, a lot of times because they do something, they secrete something that aids in digestion, or like our tongue and our teeth and our salivary glands, they aid in breaking it down initially. So they're all sort of accessory organs. So the liver, a main part for digestion with the liver is it makes and secretes bile. And then of course it also works to purify the blood. So things that you eat, things that are in there that you may or may not need, or what the body doesn't need in as much quantity, or whatever it is, the liver is our purification system, containing newly absorbed nutrients that are coming from the small intestine. So that's where the liver comes into play. Bile has a big role in digesting fats. So even though there's a question in your handout that says, what are the 2 organs that have to do with the breakdown of fats? What it's looking for is liver and gallbladder, and that's because of the bile. But this here says the pancreas, enzymes break down sugars, fats, and starches, and also makes hormones. That is true. So I mean, technically, the pancreas does affect fat, digestion as well. But that handout specifically is looking for pancreas and liver and gallbladder. It's because of the bile, yeah. So bile has a big role in fat digestion. So gallbladder stores bile. So the liver secretes bile, the gallbladder stores bile, and it helps to digest fats. So a lot of times, like if someone's having gallbladder attack, or after they have had their gallbladder removed, they can't eat certain foods that are higher in fats because they don't digest it as well. And then pancreas, enzymes break down the sugars, the fat, starches, also makes hormones, of course, like insulin. So we know that the pancreas has a lot to do with digestion as well. So just a little bit more details on this slide, but similar to the one that we just looked at. So digestion of fats, production of bile in the liver, production of glucose. If so, the liver. Remember, some of our medications reduce the amount of glucose that the liver produces. So you can see how that kind of can help you remember different things from different chapters, because you can kind of tie. The gallbladder, digestion of fats, like we just said, storage of bile. And then the pancreas, this is focusing on the pancreas with digestion of carbohydrates, specifically pointing to insulin. But all these organs, for like our level of understanding, a lot of times we'll just do the very 32,000 feet idea of what the main purpose of an organ is, but they do other things. Our bodies are way more complex, but we're not trying to be doctors, right? So we don't have to go down those tunnels. But so that's why this is sort of just highlighting the big function of the pancreas is, yes, it produces insulin. So that's an important thing for you to know. And I see I have a whole bunch of notes here on the side of this slide, so you guys can read through those. And sometimes I just put things that I think are interesting. And it might not probably necessarily be on an exam or quiz. Just sometimes I add stuff for helping to kind of clarify an understanding of something. So you'll see that when you go through these slides. Okay, so the stomach, so for digestion of protein, so we have our histamine receptors in the body. We talked about the histamine 1 receptors last week, having a lot to do with dilation or allergies and bronchodilation and contraction. So we know that histamine 1 has a lot to do with our respiratory system, right? Well, there's histamine 2 receptors, and there's a lot of those in the GI tract. So medications that have to do with GI conditions, a lot of them work on histamine 2 receptors, either usually blocking. So H1 receptors located on smooth muscle, on the bronchi, capillaries, heart, and GI. There are some GI receptors, but remember, sometimes things have a greater affinity. So just because there are some receptors in some random place doesn't mean that that's the main place where a medication is going to try to work. There may be some side effects because there are some receptors there, but that doesn't mean that that's like the main objective of a medication. It'll focus on some other area that might have a higher affinity for that. Those receptors and medications line up a little bit better, if that makes sense. So histamine 2 receptors located in the brain, the stomach, heart, blood vessels, and highlighted here for really important for you to understand, to remember, is that histamine 2 receptors stimulate stomach to make more hydrochloric acid or stomach acid. So that's really important point to know. Histamine 3 receptors, we don't really talk very much about. Presynaptic, located on histamine releasing cells, inhibits histamine release. We really don't. I think it's interesting maybe to know there's histamine 3, but you're not going to see that creep up on quizzes or exams. You might see it as like a throw you off, like which one is the right one, H1, H2, H3. But other than that, knowing which one is the important one and not getting confused is more important than specifically remembering what H3 does. Does that make sense? You just want to know which is the right one. So still dealing with the stomach. So we're still in the stomach. There are 3 cells that you really want to be familiar with. And those cells are the mucous neck cells. These secrete mucus to line the stomach. So mucus, that's sort of intuitive. Mucous neck cells secrete mucus, right? So definition is sort of in the word. Parietal cells can get a little bit trickier. They contain H2 receptors. They secrete hydrochloric acid or stomach acid, and they require a protein pump. So they're part of the protein pump mechanism in the body. So some things are just going to reduce stomach acid. Some things are going to bind up the pump. And our guest speaker describes this really well. So I don't want to add a confusing, not as well described explanation for this system, because he's far more of an expert on it. But that's basically what happens. Sometimes we're just neutralizing acid. Sometimes we're shutting off acid production. Sometimes we're binding up the system that makes the acid. So it's different things. But just if you know that these things are connected to parietal cells, they contain the H2 receptors, secrete stomach acid, and they require a protein pump. So then there's the chief cells. They secrete pepsinogen, which breaks down the protein. Pepsinogen converts to pepsin once it meets the acidic environment. So if we neutralize the environment, then we're not going to get this conversion of pepsinogen to pepsin. So you can see how a different medication might affect this system as well. And I think, yeah, when we talk about the different ones like antacids and the different proton pump inhibitors like Prilosec or something like that, when we start to talk about those medications, it'll help kind of piece these things together. And then this slide, I didn't really like. I think it's release parietal cells secrete the I think it's just trying to show the natural flow of what happens in your body if you're not actually affecting any of these systems with a medication. So the histamine goes to the receptors in your stomach, and then it's gonna, the parietal cells are gonna secrete the hydrochloric acid, which is you need to have the hydrochloric acid to make this conversion from pepsinogen to pepsin. So I think it's just kind of showing the flow. That's what that slide is for. Okay, so yeah, I am recording it, yes. Yeah. You need stomach acid. So you need an acidic environment. Yeah. So hydrochloric acid or stomach. Sometimes it's referred to as gastric juices. Other times it's referred to as stomach acid or hydrochloric acid. Okay, so then we'll be talking about a couple different conditions. Gastroesophageal reflux disease, or GERD, is one of the most popular, or not popular, but common ones. Peptic ulcer disease is also very common. Inflammatory bowel disease, or IBD and IBS, are different. They're different things, but they can have some overlapping. Irritable bowel syndrome and irritable bowel disease. Constipation and diarrhea. So the ones with the little star or asterisk or whatever that is the most common. The etiology of GERD, it's the most common chronic condition in the upper gastrointestinal tract. So lots of people experience GERD, reflux or backing up of the gastric stomach into the esophagus. So that's that heartburn, because the stomach acid is basically coming up into this. Most common complaint or symptom is heartburn, but sometimes people just talk about stomach pain. So you can have like just like a pain that almost feels like it's on the outside of your stomach, like in and around your stomach. So it doesn't just have to feel like it's coming up in your esophagus. Risk factors: drinking alcohol, smoking, eating spicy foods, aspirins. Oh, this is the answer. What medications can contribute to GERD? I found it. Thank goodness, because I was like, this makes no sense. Okay, there's your slide for that question. So aspirin and NSAIDs, calcium channel blockers, tetracycline, and then Fosamax, which is a treatment for osteoporosis. So all of those can increase the GERD. So for treatment, the number one thing is lifestyle. I tend to get GERD incredibly easily, and I know exactly what I have to do to not have it. And it's all lifestyle. Like when I change certain dietary things, when I eat at different times of the day, I don't eat so much at night, don't eat heavy at night, so I don't go to bed with a full stomach. All these different things completely affect me. So, and that's the same with for many people. So lifestyle changes are a huge first line of defense. But then there's medications, eliminating foods that aggravate it, sleeping with an elevated pillow, losing weight, exercise, and then there are some medications. Dental erosion, a lot of my molars don't look quite this bad, but these little, you guys will see this when you're in clinic and you're looking at your patient's dentition, where isn't just flat. People can, when they're cusped, when the cusp tips are cupped out, a lot of times that's indication of acid erosion. That's like, and that's a lot of, just like this, you get these little cuppings. This is fairly severe because you can get some thinning down through these other areas here. But a lot of times this cupping around the cusp tips, that's indicative of GERD or acid erosion. Peptic ulcer disease, PUD, it's a group of acid peptic disorders of the upper GI tract, primarily the stomach and the duodenum. So here's that term duodenum again. Gastric ulcer is in the stomach. Gastric ulcer, it's in the stomach. If it's a duodenal ulcer, it's in the duodenum. More common for ulcers to actually be in the small intestine, in the duodenum, as opposed to the stomach. A lot of times people are like, oh, my stomach hurts, I bet I have an ulcer. But we just say that, it's just kind of like a common thing, but it's more common for an ulcer to actually be in the small intestine, in the duodenum. So this is super important. I should have highlighted this. This is very important for you guys to know. This kind of a question will certainly be on it. Etiology of peptic ulcers. It used to be that people thought it was just too much stomach acid and your stomach was eroding your stomach, and that's why people had ulcers. But then they discovered that 90% of ulcers are not acid erosion. It's from Helicobacter pylori. So H. pylori is what they call it. So that's very important for you guys to remember that. So this bacterium, H. pylori or Helicobacter, that causes up to 90% of gastric and duodenal ulcers. Hypersecretion of acids in the stomach also can play a role, but usually it can like worsen it really. And it potentially, if somebody has like crazy significant acid production, that might trigger it, but like you can see, like most of the time, 90% of the time, it's from the bacteria. Usage of NSAIDs can also contribute or start this problem as well. And then of course, these risk factors. So if people have like, say people have three things, they take a bunch of NSAIDs, they smoke and drink alcohol, and they have a very acidic stomach, maybe H. pylori doesn't play a role, but in general, you can see that the majority of people, an ulcer is triggered by the bacteria and then worsened probably by these other things. So here's just a little diagram that kind of shows the natural healthy image of your lining of your stomach and intestine. With you have the mucus protective layer, you have the mucosa, you have all these different layers, submucosa, and then you have this defensive coming up from within, and these cells from within, you have all these defensive forces protecting. And so then the assault is the gastric acidity of your stomach. Yeah. The most is the duodenal. The most common peptic ulcer is the duodenal. So in the duodenum, as opposed to the stomach. Mm-hmm. And then, so the damaging forces are like the enzymes and the acidity, the gastric juices. And so if you have an increase of defensive forces, like the H. pylori, NSAIDs, aspirin, cigarettes, alcohol, hyperacidity, duodenal gastric reflux, all these various things, that's going to increase damage and then impair your defense. So then you end up boring a hole through all these healthy structures down into the lower levels of the stomach, and that's when you have a bleeding ulcer or an ulcer. Okay, so symptoms, epigastric pain, so a lot of pain in and around the stomach. Food or antacids usually relieve the pain, so people feel some relief by eating a more bland diet or taking antacids. This kind of perpetual feeling of hunger may be present. Heartburn, belching and bloating is also present, and acid secretions keep breaking down the lining of the stomach. So once you have this injured area, it's just a very susceptible area. So it's going to keep sort of attacking this susceptible area. So pharmacotherapy is treatment. We'll talk about, the guest speaker will talk about that. Lifestyle changes is, of course, not doing all the things that can aggravate it. So not smoking, not consuming alcohol or decreasing it, decreasing caffeine and NSAIDs. Inflammatory bowel disease, or IBD, that is chronic, long-lasting disease resulting in inflammation of the mucosa of the colon. So that's your large intestine, so not duodenum, jejunum, and ileum, but your colon, your large intestine. It's inflammation of the mucosa of the colon and the rectum, which causes a destruction of the bowel wall. So it's the second half of your GI system, the lower part. Bloody diarrhea and abdominal pain are symptoms, anorexia and weight loss. And there's two different types. You can have ulcerative colitis or you can have Crohn's disease, and we'll kind of break those two down. Ulcerative colitis is an inflammatory disease of unknown cause, so they don't really know necessarily what triggers it. It's probably maybe genetic, maybe environmental. Thought to be associated with immune dysfunction, limited to the large intestine and the rectum, characterized by periods of remission and relapse. So when people have ulcerative colitis, it might like rear its ugly head, and they might have to deal with a lot of problems, or maybe they notice something that triggers it in their life, but then, you know, they might be able to get through that, and then it kind of subsides again. MS is a similar, kind of has these episodes of like, starts to rear up and then it kind of goes into remission a little bit. Crohn's disease is a little bit different than ulcerative colitis. It's characterized by intestinal ulcers, interrupted by normal appearing mucosa. There's a genetic predisposition to Crohn's disease. And with ulcerative colitis, maybe there might not be a genetic predisposition, I guess is what they're saying here. Characterized again, similarly, remission and relapses. The ileum, so a little bit of I think that's misspelled. A little bit of the small intestine, and then the colon affected most frequently, but can affect the entire GI. So that's really important to note. Somebody with Crohn's disease, you can see evidence of Crohn's disease in some people's mouths. So that's really important as dental hygienists for you guys. There's some good CE classes on Crohn's disease. Because you might see like ulcerations in somebody's mouth. So it can literally affect, you know, from one end to the other. More commonly in the larger intestines maybe, but that doesn't mean that you wouldn't be able to see effects of it in the oral cavity. So that's an important point to note about Crohn's disease. Pharmacological therapies, it can be managed but not cured. So ulcerative colitis and Crohn's disease just are sort of managed conditions. And then 70 to 80% of people with Crohn's disease require surgery. A lot of times they'll end up having to cut out like the parts of their diarrhea and constipation. What are the causes? I don't know why this is missing. Oh, it's going to appear slowly. So diarrhea can be from food intolerance. What else? Viral infection, stress. My dad used to call them the nervous poos. It's probably TMI. I think I got that recorded. Medication. So medications can cause diarrhea and a pregnancy. Oh, go back. Hold on. And then constipation, not getting enough dietary fiber. That's a big one. Nobody likes to eat too much, so we all tend to need more of that. Narcotics can cause constipation. Oh my gosh, slow your gut right up. I don't know why anyone would be addicted to narcotics. Iron supplements, and then children can be afraid to go poo, and so then they hold it, and then it backs up, and then they can't go at all, and it can be just a nightmare. My kids never had that issue. I love sharing like way too much stuff about this topic. I don't know why. Certain foods, red meats, gluten, fast food, dairy, and alcohol can also cause constipation as well. Disorder of the GI. So irritable bowel syndrome, a little bit different. There are some similarities to irritable bowel disorder, but it's not quite the same because it's not necessarily as severe. It can be very disruptive to somebody's life for sure, but not necessarily maybe as severe. But the symptoms for IBS tend to be diarrhea and constipation and abdominal pain. So it's disruptive, especially if it's diarrhea. That's very disruptive, and it can be uncomfortable. And in order to be diagnosed as IBS, it has to last for longer than 12 weeks. And then must rule out other conditions such as things in your diet or stress or medications that could be causing it. And that's it. So we don't talk very much about that. I don't even know if our guest brings up IBS. Okay, so that being said, it's 9:05. I am going to take this opportunity to see if I can get someone to troubleshoot the projector so that it can set up a little bit nicer, hopefully, for when our guest comes at 9:20. So you guys can have 14-ish minutes to use the restroom, talk amongst yourselves, and I'm going to see if